We'll jump right into this. This talk. So the purpose of what I was asked to help you folks with is just a general overview of critical care. We've spent the last 3 talks on mechanical ventilation. So the plan material was if there's 2 black box things in the ICU that you really need to understand, mechanical ventilation is one of them, and then vasopressors. So you guys learned this stuff in paramedic school, but
Sorry, sir.
this is not
Sir.
stuff you're probably doing a lot every day. So
Thank you,
pressing
Colonel.
on, I think this is also one of the things you could be charged with managing or at least understanding. So we'll go right through this pretty quickly. This is also good stuff for registry review, and it's all on this is all fair game for National Registry as well. So stuff you need to know, just not stuff you may or may not be using quite frequently. So we're going to talk about some of the mechanisms. I'm going to go through that part really quickly. I can come back to it if you want to get nerdy about it, but I do want you to understand how these agents work. But I really want to focus on the clinical applications. That's what you're going to want to know. Dosing, things to watch out for, and then finally we'll review the evidence, and I'll try to put that in the context of how we would do this with COVID. I don't think this talk will take very long. It'll open up some time at the end for questions, okay? And bear with me because, you know, we're starting to heat up here. We have our biocontainment unit activated, and we're predicting our peak is going to hit us on the 18th of April. So we're behind you guys in New York, but we're anticipating that influx, and many of us have been literally living at the hospital. So bear with me. Okay, real quickly as well. So other things that are important. I know that there's a lot of thirst for knowledge right now. This Maryland Critical Care Project has a ton of basic critical care lectures that are completely free. I just want you folks to know about this. Has some really good stuff. And in fact, we have a new COVID project module that we now have as well. So everybody's been tracking on a lot of different information, but this is one free bread and butter critical care free thing that you can access. And there's also podcasts, lots of podcasts. The other one is if you just want one single source to read, again, I do have to have the disclosure here, the ICU book, looks like it's showing upside down. This is a really succinct guide. I don't get any, I'm one of the authors on this, but I don't get any money for it. I just want to be clear. Dr. Marino does, but this is a really good book that covers the basics of critical care that you can read literally in almost 2 days, quite frankly. So if you want one book, if people ask me this all the time, if I could have one book, crash course in critical care, what do I read? I'm sorry, this is it. This is the one I think, the little ICU book, okay? So that's it. All right, jumping into this. Let's talk about mechanisms of action. Everybody's familiar with beta receptors and alpha receptors. The bottom line is these receptors, when activated, increase cyclic AMP, and that triggers a cascade that allows these drugs to work. And it depends on the receptor because there's different levels of cyclic AMP that are activated. But what it basically does is mobilize ATP, and then it helps your muscles contract. That's the bottom line with this stuff, okay? So we're going to go through this really quickly. Calcium has a central role. This diagram shows the different mechanisms for different agents. So depending on the receptor, the common pathway is calcium gets increased intracellularly and allows your 2 actin and myosin fibrils to interact and contract. That's what's going on when we give a vasopressor or an inodilator or an inotropic agent. That's what's happening. So this is a complicated diagram. You'll have access to these slides afterwards. You can review this. I just want you to focus in on calcium. And then more complicated diagrams, and I'm not sure why I even added this here, but I'm going to press forward. So to summarize how vasopressors work, G proteins increase the denylate cyclase, ATP is mobilized and phosphorylated, leading to calcium and contraction of muscle fibers. Those muscle fibers can be smooth muscle fibers if we want vasoconstriction, or they can be heart fibers to control contraction in the heart. It depends on which receptor is activated and where it is in relation to those fibers. That's how these things work. And that's about all I'm going to say about mechanisms today. I know I'm blowing through this, but let's get right to clinical applications. And in fact, let's just get right into the drugs. So the first one to talk about is Epi, which you all know. You've been trained on this. You've given it. Epi is really, I'm starting at the top of the pyramid in terms of the most potent vasoconstrictor and most potent inotrope. When we're using it with these patients in COVID, and we are using it with COVID patients because a lot of them have myocardial dysfunction. We don't know what the overall prevalence is. It looks like it could be upwards of 20% in some populations or even more. And when we look, we find it with echo. So that's the problem, is how do we treat that? We are putting patients on what we call low dose epinephrine, inotropic dose epinephrine, as you see listed here, 0.01 to 0.05. You're not going to remember that, but I just want you to what I do want you to remember is if you just want the inotropic effect of epi, it's a low dose, okay? Because if you increase the dose of epi, you're going to get exactly what you'd expect, more alpha and more beta together. You're basically going to nuke the heart. It's a very, very potent both inotrope and vasoconstrictor. But if we use it at lower doses, we get more of the inotropic effect. That's an important critical care consideration for epinephrine. That's how we use it with patients that have right heart dysfunction or heart dysfunction related to their respiratory failure, okay? So you'll see this if you're seeing it on a pump or if you're helping manage this or monitoring it, okay? This is how we're going to probably be using it for that role. It's also a backup if you're in trouble with it's also a backup if you're getting in trouble with a lot of hypotension. Things to watch out with epinephrine. It can cause lactic acidosis, all right? So if your lactate levels aren't coming down, they're kind of hovering at an intermediate dose, that can be a problem. Hyperglycemia can increase your sugar, okay? And tachydysrhythmia, so it can cause heart rate increase. So let me pause for a second because I'm already getting pinged on alpha beta. So let's go back. I'm sorry, guys. I might be going a little too fast. I apologize. I can slow this up at any point. There's no rush here, but I do want you to understand. So going back to alphas and betas. So this diagram doesn't exactly explain it, but it's pretty straightforward how this works. If you have an alpha receptor that is activated, the alpha receptors work on the smooth muscles of the blood vessels, okay? So this whole reaction that I'm showing you here, it's not a beta, but it's actually an alpha receptor. It's the same mechanism, but it's not in cardiac muscle, but smooth muscle. Alpha receptors, and I'm being very general here, cause vasoconstriction. They tighten up your blood vessels and increase your blood pressure. Beta receptors, beta 1 receptors are very specific for cardiac fibers, okay? So if you activate a beta receptor, and that's what we were just getting into is epi, that's going to increase the cardiac muscle contractility. It does have effects, so epinephrine has also alpha effects, so it can hit the smooth muscle and cause vasoconstriction, but it also works on the beta receptors. The beta 2 receptor is yet another beta receptor, so not cardiac tissue, but now lung tissue. And that activates the same process, cyclic AMP, ATP activation, intracellular, in leading to bronchodilation. So alphas, smooth muscle, vasoconstriction. Beta 1, cardiac tissue, just like you're seeing on this slide. Beta 2 gives you bronchodilation, okay? So that is, I skipped over that, I'm sorry, but I hope that explains it. We can come back if you guys, sir, you good? Yeah, good. So back to the drugs, and I know I'm going right into this. Here's the thing to worry about with epinephrine. I just told you that if you want to get the inotropic part of epinephrine, in other words, you want the heart-only part. You just want the heart to pump a little better with it. You got to be careful with that dosing. That's where this dose right here that I list, this 0.01 to 0.05. Don't worry about the dose. Just remember, it's a low dose. If you go higher than that, you get more alpha, not beta 1. So like we just talked about. And in fact, if you really crank up epinephrine really high because you're hypotensive, you can cause decreased hepatosplanchnic perfusion, and you can have infarcts in the bowel and basically the intestines. And that's very bad. That's almost, in these patients with COVID, if we get that, these are not patients we're going to be taking back to the operating room for exploratory laparotomies and bowel resections. They're going to die. So we got to be careful. Epi is a very potent vasoconstrictor, and that's why I worry about using this in huge areas where we're treating hundreds of critically ill patients, because you got to pay attention to the dosing. You really do. If you overdose them, you can really do some damage to their end organs. But it's a very powerful drug. It's the big gun. It's our first drug of choice, as you know, for ACLS. It's without question if you have an anaphylactic shock. And we could see that. Again, I know a lot of what we're talking about here is COVID specific. If you have anaphylaxis from a drug that as a secondary problem in a COVID patient, then yes, epi is the drug of choice. But I just want you to remember that inotropic dosing. Remember that what we're really talking about with COVID patients is going to be more of the inotropic use of this. But it's also a backup vasopressor. If you dial it up, it will cause more alpha, and it gives you all the effects, okay? But it's very, very potent. So that's kind of the top dog in terms of vasopressors, epi, strongest. The second most, and this is going to be the one you're going to see used first and foremost, is norepinephrine. So structurally, it looks very similar to epi. I don't have the chemical structure up here, but this is a mixed alpha and beta adrenergic agonist. More alpha, though. More alpha. The primary effect is arterial and venous vasoconstriction. The good news is you get fewer metabolic effects than epi. So that hyperglycemia that I was talking about, the lactate increase that you can get with epi, less with norepi. And here's some dosing ranges. What I would encourage you, again, this is not a talk where you're going to remember the doses. I don't expect that. Maybe you will, but it's okay to cheat and look at the card. But my point here is what you're seeing, and you'll see as we talk, is weight-based dosing. Why is that important in a pandemic? Well, it's important for a couple reasons. Number one, that we believe is the best way to dose these drugs based off of actual body weight, or I'm sorry, ideal body weight. Just like we were talking about tidal volume, you want to dose your vasopressors, if you can, by ideal body weight. What we believe that can help us with is conserving the drug a little bit. When we dose it by just micrograms per minute, non-weight based, we wind up using a lot more drug. That's what we believe. So that's just a pandemic specific thing about dosing. But our dose range here is, we can start off with just a whiff, like 0.01 mics per kg per minute. I had a patient last night, for example, that was septic, and we were on 0.04. Not a lot, just enough to keep that mean arterial pressure greater than 65. We titrate to MAP, mean arterial pressure. And so you titrate it accordingly. When you start to get into really high doses, you need to think about a secondary agent to add. But norepinephrine is going to be your first line. It's a really good vasopressor. And this is our first line vasopressor to increase blood pressure in septic shock, okay? By the way, even though it cranks on the blood vessels, it's a very potent vasoconstrictor, it actually can increase your renal and perfusion to your intestines, especially when you compare it to other drugs like epinephrine and dopamine. But if you're using this as a sole agent, because it has so much alpha, it has a little bit of beta 1, so it can give you a little bit of heart squeeze. But most of what it's doing is cranking on your smooth muscle, your blood vessels, causing your blood pressure to go up. And so that's a problem. If your heart's struggling, you don't want to have blood vessels that are tight. The heart is trying to pump against those tight blood vessels, and that's an afterload problem. That's an afterload problem that you need to be careful with. So the point here is you have to dose it appropriately. If you dose it really high, you will get necrosis of digits because it will cause distal vasoconstriction in your disc digits. And I'll show you some pictures of that in a second. This is your first choice vasopressor for vasodilatory shock. So septic shock, COVID-19 patients when they're getting septic or presenting in sepsis, and many of them are, this is your first line agent you're going to start titrating. You're going to start with norepinephrine if you have it. It's a good choice for all forms of distributive shock. Distributive shock, remember, is the type of shock where your blood vessels are just loose and wimpy, and we need to tighten them up to get that blood pressure back. They're loose and wimpy because they're inflamed. and and they're just vasodilated. So that's what this drug can do, is actually help increase your blood pressure and tighten things up. That's norepinephrine. You know, I'm going to skip this slide. There's some reviews on this stuff. There's no vasopressor that's been shown to have a benefit over another in septic shock. But what I'm telling you today, we believe that there is a sequence of how you should choose your vasopressor for septic shock. In other words, norepinephrine, we believe, because of the safety profile and the way it works, that's our first choice. But I do want to be clear that there's no drug that's superior without doubt over another one. And that's why I do want to talk about a couple other vasopressors as well, including vasopressin. So you're familiar with vasopressin, for those of you, all of you guys who have taken the previous version of ACLS. This was used in ACLS. So I know you know about this drug. You probably have given it. You might have heard about some use in trauma. That's a separate talk. We are really talking about shock states. Specifically, septic shock is really the one I'm focusing on today. And vasopressin is a good second-line drug to think about, okay? It's a stress hormone. It's synthesized up in the brain in the hypothalamus, stored in the pituitary. And when you get really sick, you become vasopressin deficient. And what happens is we can supplement that by giving vasopressin. So if you're on norepinephrine and you're cranking it up and you've given some fluid, you're resuscitating, and now you're still hypotensive, this is a second agent you can add. And the way it works is it works on different receptors. It works on actually the vasopressin, the V1 receptor, which is in your peripheral blood vessels. It's in your liver, brain, and kidney. But you get vasoconstriction with this. There's some other effects here that I list, but you get vasoconstriction. So it tightens up the blood pressure, the blood vessels, and increases your blood pressure, okay? So it functionally works as a vasopressor. We know in septic shock that patients are vasopressin deficient. Here's some numbers for you. Nothing to remember except for the dosing, because vasopressin's a little different. If we go with vasopressin, there's no titration. Most of us that do this stuff, we don't titrate vasopressin. We just turn it on or we turn it off. And the range of doses is between 0.1 and 0.4 units per minute. And when you give a dose like that, that increases your vasopressin dose or your vasopressin level in your body dramatically. And it can reduce your norepinephrine requirement. The norepinephrine can come down quite a bit. It doesn't have any intrinsic catecholamine receptors, so this doesn't work on the betas and the alphas that we just talked about. Separate pathway. That's a good thing. So it shouldn't hurt the heart. It shouldn't squeeze brain vessels. It shouldn't do much in the pulmonary vessels. And COVID, as we're learning, is really not just an ARDS. There's actually a lot going on with blood vessels. So this may be a good vasopressor to think about with these patients because it works through different mechanisms. Okay? But if you use this indiscriminately, this is what you get. You will wind up with amputations. What it'll start with is this finger. You see how that cyanosis, that nail bed cyanosis, that can be an early sign. So when you're examining these patients, you know, we're not going to have a lot of sophisticated stuff in COVID to mount into. You might have an A-line, you may not. You may have a non-invasive blood pressure. What you do have, though, is you have capillary refill, and you have the ability to look at the digits and take a look at that. You may not be able to feel them because you're going to be gloved up pretty aggressively, okay? But you can examine their digits, and I would argue that, you know, cap refill is one of the things to rely on. And while you're titrating vasopressors, take a look at this to make sure you're not cutting off their digits. This is an unfortunate consequence that we see. We see this when you start vasopressors without doing all the fluid resus first. And I'm not talking liters and liters of fluid, but without any fluid resus, and we just try to use vasopressors to increase blood pressure, we can wind up causing severe distal vasoconstriction, which can lead to amputations and stuff, okay? So something to watch out for, something you have to monitor. Like every drug, these drugs have side effects. This is one of the side effects you can see with vasopressors. All right, you know, I don't want to get nerdy, but I know there's guys out there, there's high-level folks on this call. So for completeness sake, you may see in some cases that you may be running out of norepinephrine where you're working. We're not. We have plenty of vasopressors where I'm at Shock Trauma in Baltimore. But I worry in this pandemic, we're having drug shortages. So today's talk, I'm going to go through all the vasopressors that are available, including dopamine, in just a second, because I think you got to know about these drugs. And I know that they're on the registry, that they're testable items. So these are things you need to know anyway. But just for completeness sake, there's the VAST trial that you may hear thrown around. And then there's the VANISH trial. Nothing that I expect you to remember, but these were trials that looked at norepinephrine versus vasopressin. So they compared the two, and they saw some differences, but there was no conclusive evidence that one drug was better than the other, okay? And keep in mind, vasopressin is way more expensive than norepi. A bag of vasopressin is about $900. Norepinephrine, depending on how you get it, can be a couple bucks. So in terms of the cost benefit, again, that's why we go to norepinephrine first. The VANISH trial also showed, there may be some effects with vasopressin. CRRT stands for continuous renal replacement therapy, dialysis. There was a little bit less dialysis use associated when they went with vasopressin. But to conclude this, the primary drug to be using in septic shock is still norepinephrine. Vasopressin is your second line agent, okay? I'm going to skip over. There's also the VANX trial. This was used in cardiac patients. So we can do a journal club later if you really want to get into this. But I'm putting this here because some of you will want to read these slides later and you can have these references. So how do we dose it? So that's the good news. Like I was saying, this is not a titration. It's on or off. And the dose you go with is 0.03 units per minute. Second line for septic shock, you don't titrate it, you put it on. Well, the way we do this is we put it on. If the norepinephrine goes down, we usually finish the bag of vasopressin and then rely just on norepinephrine. There's different thresholds of norepinephrine. I'm not going to give you the threshold that I use unless you want it. We actually crank up our norepinephrine to 0.3 mics per kilogram per minute. This is high-level dosing that you really need to be talking with an intensivist on. But the point is, you may ask your question, when do I use vasopressin? You said, when norepi's not working, how do I know what level of dosing it's not working? And that's going to depend on where you're working and who you're working with. Because most of us believe it's about a dose of a 0.3 or so before we start vaso, okay? But once we start it, we just turn it on, and then you see what happens. You don't wean it, you don't go down on it, we just turn it on or turn it off. So it's pretty easy in that regard. And that's the dose recommended by the Surviving Sepsis Campaign guidelines, okay? Dopamine, another one that's in your armamentarium that I know you've been trained on. Here in Maryland, our pre-hospital system does not have norepinephrine. We have epi, and we have dopamine. And that's just a product of, I love my system here. I'm a part of that system, but we're a little antiquated. Honestly, we should probably have norepinephrine rather than dopamine, but we have dopamine. Here's the thing with dopamine. Dopamine is now a lot more trickier than the previous vasopressors that I talked about. The reason is it's a dose-dependent response. So unlike the other drugs we just talked about, like epi and norepi, those are drugs we titrate. Vasopressin, it's on or off. Dopamine, you've got to choose the right dosage range. Or if you don't, you'll wind up with a different effect, okay? And here's the problem with dopamine. When you put dopamine on, heart rate and arrhythmias go through the roof oftentimes. At high doses, you'll get a lot of dysrhythmias, meaning atrial fibrillation, tachycardia, okay? These patients that we're seeing with COVID-19 are already really tachycardic, and they're also really inflamed. So when we put another drug on that's going to worsen that, it's probably not a great idea. And again, I just bring this up because we might run out of some of these drugs where you're at. And if you've got dopamine, it can be used. It can be used. Several years ago, when I previously was working at Johns Hopkins, for example, it's about a decade ago, we ran out of norepinephrine. We just ran out. So we had to use dopamine. And so there's a learning curve to this. And what I would say about this is the dosing here is on your left side. At low doses, you really don't get much out of dopamine for septic shock. you might get a little bit of cardiac output. Your heart might pump a little better. But you don't get much more than that. You got to crank it up to a moderate or medium dose to get cardiac output. And then if you want to get the effect that norepinephrine has, so this is all dopaminergic. The medium dose is more beta 1 receptor. So remember beta 1, heart, okay, contractility. And then if you want to get the alpha effect on those smooth blood vessels, vasoconstriction, you've got to start it at a high dose. This is the mistake that's made with dopamine, people that don't use it much anymore. They'll think, oh, it's like norepinephrine. I'm going to start low and just dial it up until I get my effect. You can't do that with dopamine. You got to go right to a higher dose with dopamine if you're looking for an alpha effect. That's the big point here. And when you get to that effect, yes, it works on the alphas more, but it still works on the betas, and that's the problem. That's why you get the tachydysrhythmias. That's why you get a lot of tachycardia, maybe atrial fibrillation. So that's something you have to think about, okay? And that's why we don't like dopamine, because it's still a good vasopressor. It has effects on the heart. It does increase the beta 1, that's true. But really where we use dopamine at shock trauma, for example, the classic case that's good for dopamine is a neurogenic shock patient, a patient with a high C-spine injury. So we've taken out T1 through 5, the nerves that go to the heart, and these patients get bradycardic, and they get hypotensive because you've now taken away their sympathetic nerves below the injury. They're cut off. So dopamine is one way we can counter that by treating the hypotension with dopamine, and also helps with that bradycardia. So that's a good indication for dopamine. But what we're really talking about here is more septic shock today, because we're trying to focus these talks more towards what you're going to be seeing on the front lines of COVID-19. This is not your first vasopressor for septic shock, but if you use it, I want you to remember, go higher dose, watch out for the tachydysrhythmias with it, okay? It's also important to mention that when you do this, you can do this on a drip, and I believe you probably learned how to do this, setting up a drip on a micro dripper and doing all the calcs. You might have to do that. So that's something I would not try to go back in your memory and do. When I do that, I go right to my phone and I actually calculate the drip rate. Separate talk. Maybe we can get into that a little Friday when we have our nursing interaction talk. But I think that you really need to be putting this on a pump if you can. It doesn't matter. I'm agnostic to the pumps. It could be an Alaris. It can be any kind of infusion pump. But you should be using a pump if you're going to do this. And so you know the dose of what you're giving. Program very carefully, because you can really get into trouble with these drugs if you don't do that, okay? Let's just talk about a couple agents. Then we're going to move into actual indications as a kind of a review to pull it together, and then we'll have some questions, okay? So because our COVID-19 patients, a lot of these patients are having problems with myocarditis, we're finding that we do need to use other drugs to support the heart. One of the drugs is dobutamine, you could consider. So dobutamine is not a vasopressor. It is what we call an inodilator. It's an inotrope, meaning that it works to help heart contractility, but it's a double-edged sword because this is a good thing for some patients, but it also vasodilates. So it's an inotrope that vasodilates. In a patient with heart failure, that's not a bad thing. We don't want them to have a really tight blood vessel for the heart to pump against. But for a septic shock patient, they're in what we call distributive shock. They're vasodilated. So if you put a drug on that makes that worse, yes, your heart might pump better, but it's pumping against tubes that are not very tight. They're nice and loose. So what I want you to remember here is this is a good drug. If you use this drug, you almost always have to have norepinephrine in the background to counteract the vasodilation you get with this, okay? It's a good drug, though, if your heart is in shock. So if your heart's not pumping because it's inflamed, myocarditis, we will use this occasionally for conditions where we really use this drug is in septic shock. Believe it or not, you can have myocardial dysfunction just from septic shock and infection, okay? So dobutamine is one of the drugs we can actually use to counteract that and help increase contractility of the heart. It also may increase your splanchnic blood flow. That, in other words, the blood flow to your intestines. That's a good thing, okay? Another drug class is milrinone and amrinone, which I won't spend a lot of time on it. I want you to think about this drug as a me-too dobutamine. It has a separate mechanism of action, but it's also an inodilator. So if you, again, have cardiogenic shock, it can increase your cardiac output, but it decreases your SVR. That's your systemic vascular resistance. So it increases contractility of the heart, but it can cause vasodilation. So just like I said before, you almost always have to, in septic shock, if we're going to be using this to help the heart, we got to give another vasopressor like norepinephrine in the background to counteract that vasodilation, okay? And the other thing with milrinone and amrinone, whichever one, we usually use milrinone, it has a longer half-life than dobutamine. Dobutamine's a pretty quick-acting agent. So if you get into trouble with dobutamine and you shut it off, whatever problems you're having with dobutamine will go away. The big problem with dobutamine is it causes a lot of tachycardia, just like dopamine, okay? So milrinone, a little bit less so, but if you run into that hypotension from this decreased SVR, that vasodilation, you might be committed to that a little bit. You might have to really wait for this drug to go away. So if you're on this for a couple days, you can't just shut it off and expect it to go away. It's got a longer half-life than dobutamine. And that's variable for patients depending if they have renal failure and such, okay? This is a real short overview of milrinone. There's a lot more we could say about all these drugs. The point, I think, of all these lectures is to reintroduce you to some of these agents that you may have learned about and or may not have learned about, just so you know what they are and you kind of know what kind of class they are and you know some of the precautions that I'm foot stomping. This is another one that we use a lot in the anesthesiology world, phenylephrine. Now, this is a pure alpha agonist. So this works only on those alpha receptors. It does not work on beta receptors. And it's good for temporary restoration of your mean arterial pressure, your MAP. Doesn't really affect the arteries in the heart. It can reduce the blood flow to your splanchnics, your intestines. And so where do we use this? So in anesthesia, when we give agents in anesthesia, it's a very predictable. Those drugs cause vasodilation, the volatile anesthetics. So even the other drugs like propofol cause vasodilation. We can counter that with phenylephrine because it's a pure alpha. The problem with phenylephrine, though, is it's short acting, and the doses. I don't expect you to know the doses. I just want you to know this is another vasopressor you've got in your armamentarium. It's not the best vasopressor. It's not the strongest, most potent vasopressor, and it really does a number on your. Remember those digits I showed you? If you're only using phenylephrine at really high doses, it can cause the same problems I showed you in that slide with those necrotic digits. But here's the thing with phenylephrine. So let's say you got a patient you've just intubated and now they're hypotensive. You can give a small dose of, you've seen us do this, those of you that work with anesthesiologists and some intensivists, you'll see we have what's called the Neo stick. The Neo stick is a phenylephrine syringe where we can push it. And when we push it, what we're doing is we're activating the alpha receptors in the intestines, okay? And that mobilizes a bunch of blood back into the circulation because it squeezes the blood flow in the intestines, and there's a tremendous amount of blood flow there normally. So what you're basically doing with this is causing an autotransfusion. That's how it works. It activates the alpha adrenergic receptors, it vasoconstricts, and you can get an autotransfusion. So that's fine in the short term. So let's say you intubate a COVID patient and they're hypotensive, and you think that maybe they're dry, you're not sure, you're giving some fluid. You could give them a little bit of phenylephrine as a short-term solution, as a push dose, and see what effect you get from that. I will say that most of these patients are very, very dry, meaning that they're very dehydrated by the time we intubate them because they're sick. And they probably have been people have probably tried to manage them with diuretics and such. So this is something to consider. I just want you to know the mechanism of it. It's not the best vasopressor in the world, but it's one more in your toolkit. And again, if we go back to drug shortages, we have a lot of this in the operating rooms because we use it we'll use it a lot in anesthesiology because it's a good short-term solution for some of the side effects of our anesthetics at times, okay? All right, one other drug to talk about. Yeah, I'm going to talk about it. It's FDA approved. This is one other vasopressor. So another whole different mechanism. This is angiotensin 2. Angiotensin 2 is a natural hormone circulating in your blood, and it's cleaved by the ACE inhibitor to angiotensin 2, which is a very potent vasoconstrictor. So we have a drug now, which we've had around since the 1930s, but it's just recently had a resurgence, and it's a very short-acting, very potent vasoconstrictor, okay? Doesn't work in the same way as alphas and betas. It's got a separate mechanism. It's basically a direct injection of a vasoconstrictor. It works directly on receptors on the blood vessels to cause vasoconstriction. Very potent vasopressor. It's expensive. It's got a resurgence. There's a trial. I'll show you the trial. This is the ANG2 ATHOS 3 trial, which is not a huge trial, 344 patients. So they compared this to a couple different drugs, and they found that the angiotensin 2 group, the group that got angiotensin 2, had a really good response to this drug. We have a protocol at Shock Trauma where we're going to specifically look at using this drug in COVID-19 patients. Some centers are already doing it. We just don't know if this is if this is a better vasoconstrictor for COVID-19 or not. But I will tell you that this is an FDA-approved agent for septic shock. It's not frontline, but it's been studied and it is approved. It's not an experimental drug. So if you hear about this drug, the trade name for it is Giapreza, okay? And the problem with this drug is it's really expensive. It's not cheap. So it's yet another really expensive drug. That's why we haven't endorsed it as frontline, but we've studied it at our institution. We were one of the places that did the ATHOS 3 trial. And so we're familiar with this drug. I've used it on several patients with good effects. Very powerful vasoconstrictor. So it's one more to think about. You might have access to this where you are, okay? More studies, I'm gonna go through that. This is a case that I wanted to show with angiotensin 2. I'm gonna skip this. I can summarize it quickly though. This patient had a really high dose of norepi. We were giving a bunch of ridiculous agents that we do secondarily, which I'll show you in just a second. Pump the brakes for a second. So this is a case, not a COVID case, but this is what we do. This is bread and butter ICU medicine, okay? 70-year-old male, has colon cancer. Not a great prognosis, by the way, but he winds up in the ICU with septic shock after they resected his cancer. They tried to, okay? Now, that might only give him a couple months to live. Who knows? But the point is, he's sick because, unfortunately, he got septic because he had other holes in his intestine that leaked out a bunch of crap into his body and made him really, really sick. So here's the deal. What you have on these graphs, this is a blood pressure graph, okay? So what you're seeing here is you can see systolic blood pressure. Sorry, I just got to move your thing so I can see it. So there you go. The top number here is blood pressure. The middle number is your mean arterial pressure, and then the lower number is your diastolic blood pressure. This is a blood pressure graph. And I would also encourage you in general in ICU medicine, trending is absolutely vital. Trending is vital. You got to look at the trend. You can't just take one blood pressure and react to it. You need to trend it out a little bit and look at the trend of where you've been. The lactate is there's a whole separate talk on lactate, okay? We'll get to that at some point. But lactate is a good marker of how well your resuscitation's going in general. It's a good marker of, well, it's a marker of a lot of things, but when it's high, it's not good. This patient's lactate was climbing. Now, here's the norepinephrine dose. That's the red graph. And look at how high you were going, 0.4, 0.3. These are high doses, really high doses. And despite this, the blood pressure is still sustained, but the lactate's going up. There's a bunch of things in here. The patient got antibiotics. The patient had an operation, first of all. This is all after the operation. A bunch of other things, antibiotics, meropenem's an antibiotic. These are some adjuncts to help improve the blood pressure, which we'll talk about in a sec. And you can see the vasopressin was also started and maintained. So what they were saying to themselves is, look, we're throwing the kitchen sink at this patient. We have a lactate that's going up. Our blood pressure is maintained, but only with ridiculous doses of drugs. How about we start angiotensin 2? So they did. They started angiotensin 2, and almost immediately the norepi dose came down. The vasopressin was able to be weaned off, and they weaned the angiotensin, and this patient got better pretty quickly. The lactate came down. This I show you as an example. It's a good example of how a good resuscitation can go, number one. But number two, it's a good example of how to use something like vasopressin. I'm sorry, angiotensin 2 and vasopressin and norepi. So this is where angiotensin 2 really helped us in this case by decreasing. We were able to consolidate down to one drug. Really low dose of norepi was kept in the background, but we got off the vasopressin, low dose angiotensin 2. It bought us some time to let this patient recover. The problem is if you can't get to a point where you get out of this trap of escalating vasopressor doses, that's where they'll wind up with irreversible shock and die, okay? So a rather dramatic case. This guy made it out of the hospital. He's 70 years old, doesn't have a great prognosis, but hey, you know what? Maybe he'll see a graduation or something, you know, and we declare victory on that. You know, he's alive. Okay. Doc Rush, I'm going to skip over these because I want to get right to the end. I see our time here, and I think there's probably a lot of questions. I'm going to leave this slide for a second and just say this. I don't think we're going to have the luxury of using these drugs in these patients, with the exception of maybe vitamin C. These sound like great ideas. These are vitamins, guys. And I'm going to, at the very, what I'll do here at the very end is I'm going to give you a link to my COVID-19 resources. You guys can have that access, and you'll see some stuff about vitamin C. Really experimental, nothing proven. Some places are throwing vitamin C. The idea with vitamin C is, and the metabolic pathway can help your body create more catecholamines, possibly. And there's an interaction with steroids, and it could work to help improve blood pressure, but it's all unproven, honestly. It's not proven. So if you hear anyone tell you that, I'm telling you, it's just not. These are other agents. If you're at your wit's end, you're at really the last dose of everything, you can throw these drugs into the mix, potentially. Vitamin C, you'd think we have tons of vitamin C. This is intravenous vitamin C. It's not that easy to get, okay? So depending on where you are, they might be using some of these things on patients. They may be using steroids. We usually have patients on steroids if they're on really high dose vasopressors. They'll be on steroids because the idea there is there's probably some degree of adrenal insufficiency, and we give this drug to make up for that deficiency, okay? But that's again, a separate talk. As I'm going through this, you know, I'm thinking, Doc Rush, maybe one of our talks might just be a septic shock talk. I have a septic shock talk, so we can talk offline. If you guys want just a good overview of what we do for septic shock, how we define it, how we treat it, I can go through that, because the COVID-19 patients are getting septic shock. That's one of the things that they manifest with. So we can talk about that. Let me zip through a couple of these here, because I'm not going to go through these. We can talk about it if you guys got questions. I'll foot stomp things in 30 seconds or less. Norepinephrine is your first line drug for septic shock. If you have heart dysfunction, you can add in dobutamine. If you need a second vasopressor in septic shock, vasopressin. It's not a first line agent, it's a second line agent. You turn it on, you turn it off. It may have an interaction with steroids. That's another thing to consider. Epinephrine is really, we talked about that first. Epinephrine is a third line vasopressor to add to the mix. Now, I'll tell you that if you're going to that level and you've got 100 ICU patients, that's where you're going to have some serious discussions about what's really going on. Because if you're going to epinephrine after you've got norepi, dobutamine, vasopressin on board, this is kind of last ditch effort. And I don't know if you're going to have the resources to do something like adding a fourth agent like epi, if that makes sense. But it is there, it's available. We endorse this. If you can do it, You've only got one really sick patient and you can pay attention to them. You might see them using epinephrine as another agent to add on top of everything else, okay? And then I said 30 seconds. I lied. I'm almost there, though. This is the last slide. Always resuscitate first. I know on a lot of the podcasts, they talk about fluids. These patients are dry. From everything I'm hearing from my colleagues in New York, in Italy, now New Orleans, we're on constant telecons with these folks trying to learn about this disease as rapidly as we can. So for COVID-19, you know, they tend to be a little dry. We don't want to flood them, but don't start vasopressors without at least determining whether or not they've got some fluid. And that's something you're going to have to do with your intensivist. Remember, if you can, to dose them based on ideal body weight. So that's a quick calculation on your phone based off their height. Try to figure that out. If you're giving bicarbonate, and I wouldn't recommend giving bicarbonate for much of this, but that's another talk. Just remember, you can't give it in the same line. It'll precipitate and just clot off your line, okay? So bicarb is a no-no when you're giving it with vasopressors.